All right, welcome to 12 lead EKG interpretation. We're focusing on step number 6, which is does it have a wide QRS or not? Of course, normal is going to be less than 12 seconds, or sorry, less than 0.12 seconds. If it is greater than 0.12, then you've got a conduction issue. Most commonly, that's going to be a bundle branch block. What makes a 12 lead EKG so cool is that you can actually figure out if it's a right versus left bundle branch block. A standard 5 lead that we use on the floor is not capable of that. So of course, if your QRS is greater than 0.12, you've either got a right bundle branch block or a left bundle branch, which, if you remember a little bit from our anatomy and physiology before, that left bundle is divided into two parts. It has a anterior section and a posterior section that exist, and so we can actually look for those. This would be a left anterior hemiblock, not hypertrophy, left anterior hemiblock, or left posterior hemiblock. Anterior hemiblocks are a lot more common, easier to see because of the nature of how it's designed, as opposed to the posterior ones, which are fanned out a lot more, and it makes it a lot more difficult to knock that out. There is a third type of conduction delay that exists that is not actually a bundle branch block, but is a intraventricular conduction delay, and that one's usually due to hyperkalemia or some electrolyte abnormality, or potentially medications. Because of what all this entails and some of the complexities of it, I will do the I'll probably do the left and right bundle branches together. Then we'll focus on the hemiblocks, and if there's time, I'll try and include the intraventricular conduction delay. So stay tuned and see how we wind up dividing this out. So bundle branches, I love this picture. It's absolutely fantastic because it is probably one of the most accurate A&P style photos that you will come across, or diagrams. You can see here exactly how thick that muscle is on the right atrium versus the right ventricle versus that left ventricle, which is so much larger by comparison. The amount of meat there really is. You can see how thick that septum is across here. But what I do like is it does lay out the electrical conduction system really well. So sinus node, internodal pathways, AV node. Of course, your valves are across here. Well, actually, it's across this line here is your valves. You've got your bundle of His through here that then divides into your right and left bundle branches. What's important to look at this is with that right bundle, if you sever it here, the entire thing's out of commission. Whereas with your left bundle, severing it here, due to NMI, tissue destruction, whatever that may be, you would only lose the anterior fascicle. And by contrast, if you severed it here, you'd lose the posterior fascicle. You'd have to have it severed somewhere much further up in order to remove the entire left bundle branch. So the right bundle branch block, what do we do to find it? Well, here's some basic concepts. So you are no longer conducting through that pathway. You're not using your right bundle branch anymore. And so because of that, all of the conduction is going to be done via cell to cell, which is super slow. It's that, person-to-person conversation as opposed to having it posted on the internet or having an announcer just shout it out so that everyone finds out about it almost simultaneously. Because of how slow it is and that it's chaotic, it's kind of got that rippling effect that it travels multiple directions at once. It's slower. That's what causes your QRS to be wider than 0.12. And if you think about it, the way an EKG is built is it's voltage over time. And so instead of your nice sharp EKG that you're used to, it's the same amount of electricity because it's traveling through the same amount of muscle. It's just a matter of it takes longer, and so that's why it appears to be a lot wider and shorter in some cases. Other important things to keep in mind is that you've got your V1 and V2 look at the septum, and for a certain extent of things, the right portion of the heart. That's the section that they're looking at. Whereas you have lead 1 and V6, which look at the left lateral portion of the heart. And so if we draw our picture here and we get our septum in place, you've got V1, V2 over here, and then you've got 1 and V6 on this side here. So each of those covers those parts of the heart. The reason this makes sense is because conduction on that right side is thrown off. Even at that distant view from the left lateral side, it's directly across from it. So it will do one of the best jobs of recognizing that something's going wrong on that far side. And I'll have a picture for you to help kind of put that together. So rules for right bundle branch block: we do the usual stuff: rate, rhythm, what's your P waves look like, your PRI. But then when you measure your QRS and you realize that it's greater than 0.12, you have to look and say, well, now that I've got a 12 lead, I can figure out, is it a right or a left block? Well, for this one, we're going to be looking specifically at leads 1 and V6. And that was why I'd mentioned it before, is that they look at that lateral side of the heart and can pick this up really well. And what we're looking for is a slurred S wave. And this is going to be just the most important criteria and one of the easiest things you can do to just quickly recognize that it's a right bundle branch block. The final item you can add to it, and this is going to be in V1, you're going to look at the RS R prime pattern, where you have an RS R prime for your QRS R prime, and where the second one is taller than the first. And it may even look something like this that shifts, or it can be a little less pronounced. May not see much of an S wave at all, but what's really important is that that second R prime is taller than the initial R wave. And that's where you get your rabbit ears that people always talk about. But again, that's in V1 that we're going to be looking for that. So here's your picture. When I say slurred S wave that we look for in lead 1 and V6, this is that slurring that we're talking about. And again, it makes sense why V6 and lead 1 look identical, because they're both looking at the left lateral portion of the heart. V1, of course, is over here, and what we're looking for on that one is that RS R prime pattern, where the second R is taller than the first. So let's apply it. Now we're not going to do this one. I'm actually going to skip, and we're going to do 251. We'll do this first, and then we'll come back to the other. So we'll just go through this like we have with every single one of them so far. And we're going to do a rate of 80. It is sinus rhythm with a bundle branch block. And what's our mean QRS going to be? Change colors here. And we're going to see that this one is positive and that this one is negative to positive. I'm just going to go ahead and say that one's probably our isoelectric as well. I mean, if you look at how tiny that is. And so we have go ahead and call it positive. So we'll say we're up. That means we're in the normal quadrant, and our AVF is ISO. And that being said, who's perpendicular to the AVF, if you look at your dial, that's going to be lead 1, and we're going to do lead 1 in the normal quadrant, which gives us a 0 degree mean QRS. Next section, we're looking for if there's any kind of pre-excitation, those delta waves, and the answer is going to be no delta. Next, we're going to look for hypertrophy, what we had just gone over before, and we're going to be looking at our P waves in lead 2, and those are pretty flat and boring. There's not much to be found there. We're going to look at our P waves in lead 1, and we'll go ahead and grab this here. And that P wave is biphasic. Second half seems a little bit larger, so we're going to go with left atrial enlargement for sure. We're going to look to see if there's a left ventricular hypertrophy or left ventricular enlargement, and you can see that the total size of your S waves pretty much don't exist, and you don't have very tall R waves either in your V1 and 2, 5 and 6. So we're going to say no left ventricular enlargement, and is my R wave greater than my S wave in lead V1? My R to S ratio, and that's definitely not the case either. So we have no right ventricular enlargement either. So that brings us up to step 6. I'm going to go ahead and we'll do a different color. Let's do some greens. We'll do step 6. So my QRS is wide. And now we're going to be looking at our various leads for those specific patterns. So we're going to focus on lead 1 and V6, and we're going to look for slurred S waves. So I'm already down in this corner. I've got a little slurring of my S here, and I know this one seems a little bit goofy, but you still have a bit of that slurring going on. But to make your final part, we're going to look at V1, and we're going to hunt for that RSR prime pattern. And this one's actually really kind of fantastic because you have the tiniest of R waves here. You definitely have an S wave below, and then you have a nice R wave up top. So we totally have the RSR prime pattern to go with that. So we'll say yes to all the criteria. So slurred S wave, lead 1, V6, and we have RSR prime in our V1. The only other thing I want to make mention of is the T waves. We've talked about it. I've mentioned it off and on, and just looking for T wave inversions. And you'll notice that in lead 1, V1, V2, V3, and even V4 to a certain extent, you have some T wave inversion going on. That makes sense because the depolarization has been slowed down of the right ventricle. That then causes the repolarization to be delayed and out of sequence, so that you wind up with inverted T waves because of that. And there you go. So we have sinus rhythm with right bundle branch block as our final diagnosis. All right, so we're going to come back to 247 now. And again, apologize for having to kick back and forth. 1, our rate is 90. 2, we have sinus rhythm with bundle branch block because our QRS is wide. For our mean QRS, 3, 4, 5. So mean QRS, we are positive in lead 1, we are negative in AVF, so we have up and down, which gives us left axis deviation. Which one's my most isoelectric? That one's a little bit tough. I would say negative, negative, maybe there, positive. I would say that one's negative for sure. So we're going to have to go with our AVR as our most isoelectric. And so I'm going to redraw. We haven't had too many of these, so I'm going to draw our dial again. And so AVR travels this direction. So who is perpendicular to him is going to be our, that's right, lead 3. And we decided we have a left axis deviation, so it's going to be up in this quadrant here. And so lead 3, you'll have to look at your sheet to recognize it, but that winds up being negative 60 degrees. So we'll say negative 60 degree mean QRS. I'd made mention of it earlier, and we're finally going to get around to this stuff, but a negative 60 mean QRS should trigger you to look for left axis deviation. And we won't, I'm going to go over it now while the opportunity presents itself. And then we'll go through the official rules as time goes. Sorry to jump around a little bit, but it's worth it in this scenario. So we'll come back to the left axis deviation stuff in a minute, but anytime you have that negative 60 for your mean QRS, you want to start thinking about that. All right, so do we have delta waves? Nope, sure don't. As for our hypertrophy, what are we going to look at? Well, we're going to look at our P waves here, and it looks like we've got maybe a little biphasic, but we'll double check up here, and sure enough, we've got a biphasic P wave, second half's larger, so we have a left atrial enlargement. Do we have what we need for a left ventricular hypertrophy, left ventricular enlargement? Sure don't, because there's no S waves at all here for us to measure and combine with our peaked R's down in V5 and V6. And is my R wave taller than my S wave? Well, we don't even have an S wave to compare to it, so our R to S ratio is something we can't do either. So at this point we really can just say all we have is left atrial enlargement. All right, so now we'll switch and take a look at number 6, wide QRS, and of course the answer is yes. And we're going to do what we've done before. We're going to look at lead 1, and it looks like we have a little bit of a slope to our S wave. We're going to look at V6, and sure enough, it's got a great slope on its S wave. And then our final check is going to be in V1, and we're going to look for the RSR prime pattern. And it looks like we don't quite have the S, but we definitely have the R prime, where the second R wave is larger than the first. So at that point, I would say that this really kind of wraps that up, and we can say that we have slurred and RS prime pattern, sorry, R prime pattern. So that's a right bundle branch block. That's all we really need. And so finding those aren't nearly as difficult as you think they might be. The final thing, I'll zip through this a little bit just because we'll spend some more time on it as we go, but we need to double check for a left axis deviation. And so what we look for is we have the mean QRS axis anywhere from -30 to -90 degrees, and we got that. When that occurs, then we just need to do one quick check of a few leads to put the picture together to double check to see if there is a, not left axis deviation, left anterior hemiblock. Left anterior hemiblock. And so left anterior hemiblock will have, we're going to look in lead 1, lead 2, and AVF. And we're going to look for positive, negative, negative. And do we have that in this case? Well, lead 1 is positive. Sorry, that doesn't show up as well as I'd like. Lead 2 is negative, more than it is positive, and lead 3 is definitely negative. So all of that together point to a left anterior hemiblock. This is really important because this is a weird case, or common case technically, where the patient has 2 out of its 3 sections of bundle branches taken out. So think about it as you've got a stool with your 3 legs, where you've got the right, and then you got the left anterior and the left posterior. And this patient's lost 2 out of those 3. Now things are functioning okay, but should they have an MI, or if they are having cardiac symptoms and it winds up affecting this, for all intents and purposes, they've got a complete heart block, where that lower half of the heart, the ventricles, aren't receiving any information from the atria and therefore aren't beating. These patients need pacer pads as quickly as you can, because especially if they're having cardiac symptoms, because you want to make sure that they don't go into this rhythm and then wind up not having a heartbeat. You want to be able to jump on top of that as quickly as you can. Alright, so let's ever so quickly do left bundle branches as well, just to piggyback off of this. So your left bundle branch block is just about as simple to figure out as your right bundle branch is. It's the same idea. Conduction is delayed through the anterior and posterior fascicles. So let's just keep it simple and think of it as that whole left bundle is taken out. Because the left ventricle is massive, it's a lot of muscle. When you do that cell-to-cell conduction, it is way slower than it is even on the right side. And because of that, you get these rounded waveforms instead of sharp ones that you would see with a bundle branch, or with a right-sided. You might see some notching, but overall it's going to be rounded versus sharp. And I'll show you some pictures of that going forward. The nice thing is we are going to be focusing in the same areas, where it's the V1 and V2 for septal. And in this case, they're actually going to be negative rather than positive that we were just seeing. And then your complexes in V5 and V6, which are lateral. And you can include lead number 1 too. Lead number 1 as well in this whole consideration. And that one's going to be positive. It's not uncommon to also see some ST depression or elevation in these cases, simply because that left ventricle is so large and the conduction is being thrown off by so much that your repolarization has also been skewed. And as we'll talk about down the road here, ST changes are related to conduction and repolarization. So it's not crazy to see this, But what you need to do again is add up the symptoms. What are they doing? How's the patient look? How are they behaving? You know, if they're having chest pain, that's important. If they're not, well, we still need to keep a close eye on them. And that's why we do serial EKGs to track to see if those ST elevation or depression, to see if those ST changes are worsening, improving, or just maintaining the way they look, and it's a baseline that you're essentially hunting for at that point. And of course, any new bundle branch block is going to be considered pathological. All right, so our rules. Just like always, what's their rate, what's their rhythm, what's their P waves look like, their PRI. And then we measure our QRS, and sure enough, your QRS is large. And since we have a 12 lead, we can find out if we have a right versus left bundle branch going on. What makes the left bundle branches unique is that you have these broad R waves in lead 1 and V6, and then you will have broad S waves in V1. So this is your V1, and this is what you're going to see in lead 1 and V6. You might have a tiny R wave in these, kind of like this guy does here. Similar to the one we were looking at before, this will just make it a bit easier to visualize, I hope. But you have the lead 1, V6. You've got that broad sloping QRS. Sorry, broad, wide QRS. And then in your V1, you've got that broad S wave. And you might have the tiniest of R waves as well, but overall you've got that broad sloping S wave. So let's apply it. And so we've got a rate of 80. We've got a sinus rhythm. Ooh, and this one actually has a first degree AVB and bundle branch block. If you want to pause it and double check the measurements, please feel free. We're going to look at our axis. And so we are positive here, we're negative here. Our most isoelectric appears to be lead 2. So positive negative is left axis deviation, and perpendicular to lead 2 is going to be your AVL. And if we're in the left axis deviation, that'll give us a negative 30 degrees. Because we're in that negative 30, think about left anterior hemiblock, but we can come back to that. But overall, we've got that for our mean QRS. All right, do we have any delta waves? Things look a little bit off, but by and large, I'm going to say no to that. No deltas. And then we'll look for hypertrophy. Really can't see much in way of the 2 lead. However, if we focus on our V1, see what we can get there. Our P wave actually looks pretty well good. There's not a whole lot going on from an atrial enlargement. So we'll say no, left atrial enlargement. We'll look at our R to S ratio, R to S, and can see that that R wave is definitely not larger than the S wave, so we'll say no, right ventricular hypertrophy. And so then we need to look for left ventricular hypertrophy or left ventricular enlargement. And normally what we would do is, yeah, we'll just go ahead and we'll take this and we'll measure it out, 10, 15, 20, 25, almost 30, and you can add, we'll say, so we meet the requirement of, the S plus R waves, greater than 35 millimeters. But the problem is this: they have a bundle branch block. And if it is a left bundle branch block, that completely removes your ability to use that as your criteria for measuring it, simply because a left bundle branch block affects conduction so badly. And so until we figure out whether this is a right or a left block, we cannot measure left ventricular enlargement until we know for sure. So let's take the time and figure out what we got. So step number 6, wide QRS. And what do we got? So we'll look like we usually do. We'll start with 1 and 6, and we're going to look for a left and a right. We have to make sure we don't overlook things just because we're focusing on a topic. Now, do I have sloping S waves like what I had seen before? And I really don't. When you look at these, not in the same way. And go ahead and look at your cheat sheet and take a look at what those graphics are supposed to be like. And more importantly, do I have the RS R prime pattern? And I most definitely do not have that in V1. So I'm going to say no, right bundle branch block. So then we're going to look for the left. What are we looking for with the left? Well, left bundle branch will have these more wide and broad QRSs, which they definitely meet that criteria. And then we have that tiny little R wave and a massive broad S wave. So we can say not Brad. We have the broad waves, and we have, let's see, yeah, we have the broad waves. That's really the biggest take home on this one. The only other thing I would mention is your T wave inversions from before. And note that, yeah, there's a T wave inversion here, here, and here, but that makes sense with that left, and even your AVL has it too, with your left ventricle depolarizing cell to cell and then repolarizing just as slowly. It's creating these inverted T waves, which aren't actually related to any kind of ischemia or infarct. Last thing, I mentioned it on the last one, so we'll take 2 seconds to hunt for it. And that's going to be for your left anterior hemiblock. And we're just going to look to see if we're positive and negative. And do we match that criteria? And we do. So this patient may very well have a left anterior hemiblock. Now that I've done that, are you scratching your head? You should be, because they have a left bundle branch block. They have a fulminant left bundle branch block, which means that the left anterior part has been blocked out too. Yes, I purposely went through this just to kind of get you in the habit of thinking about those things when we're walking through this kind of stuff. So, yes, that's positive because we already know we have a left bundle branch block. So we will say that our final answer is sinus rhythm with So our next section, I'm going to go through left anterior, left posterior hemiblocks in better detail, and we'll talk about intraventricular conduction delay. All right, thank you very much. Okay, sorry, got ahead of myself. There was one more left on this section, so let's do this one really quick. I get so excited sometimes. 1, 2, 3, 4, 5, just like we've been doing. We'll do a rate of 70, and we have I am going to go ahead and forego a lot of the little stuff and just go ahead and tell you that we are positive, positive, and our most isoelectric is going to be lead 3. So that will give us a mean QRS of positive 30 degrees. If you want to double check my work, feel free to. Do we have any delta waves? And we'll say no deltas because there's really no evidence of that. And we'll start looking for hypertrophy. So we'll look in lead 2. And lead 2 actually does have some true biphasics going on. I mean, it looks like a little bit of the mu waves. And to double check that, we'll just look over here, and sure enough, you have the biphasic P waves with the second half much larger. So we absolutely have left atrial enlargement. We'll look for right and left ventricular hypertrophy. And we're back in this case where, and looking in V1, do I have the R to S ratio? Absolutely not. Do I have, I do have the scenario where I could count these out and be 5, 10, 15, 20, 25, 30. We could easily make the case of saying that we have the, greater than 35 millimeters, but we're dealing with a bundle branch block, or we think we are. And so at that point, I can't guarantee that it's a left ventricular hypertrophy until I know whether I have a left bundle branch as well. So we'll just do question mark left ventricular hypertrophy. And so we'll change our colors real quick to green, and we'll do 6. We'll do wide QRS. And of course the answer is yes to that question. And we'll do just like we have been. So we'll hunt in lead 1, V6, and V1. And here we have our kind of broad QRSs. It is notched, but you'll notice that in this case it is R prime, R lowercase r prime. And over here in your V6, it's the same scenario of you have the broad monomorphic QRS that has the R lowercase r prime. I don't see any real slurring of my S waves because I don't have any S waves. So it really just kind of knocks out a right bundle branch block that quickly. And just looking at those 2 leads alone do a great job of giving you what you need. The final thing you do is we'll look in our V1. Do I have the RS R prime where the second R wave is bigger, or do I have a deep S wave? And I most definitely have the deeper S wave. I have you could maybe imagine there's an R wave there, but there doesn't necessarily have to be. So we have broad QRS and deep S wave. Left bundle branch block. And that right there. Only other things I want to mention is that we have that left atrial enlargement for sure, and there's no way I can prove left ventricular hypertrophy or left ventricular enlargement. So your left atrial Usually doesn't happen on its own. Usually it's because there is something wrong with your left ventricle, just can't prove it. So it's a bit of a challenge right there, and have to wait for the echo to tell us officially what's going on. The only other thing I would mention here is we have our inverted T waves, kind of exactly where we'd expect them to be. We have inverted T on our lateral leads. But funny enough, we even have them in our inferior leads as well. This patient has quite a few. The only two that aren't inverted are V1 and V2. And this is what we would do. We just double check it with the patient's medical condition. How are they feeling? What do they look like? What are the labs telling us? Always remember symptomatics. Now I'm officially done, and we'll move on to hemi blocks in the next section.